Good morning and welcome to the Department of Medicine Grand Round hosted by Hamilton Health Sciences today. We're pleased to have Dr. Anna Cvetkovic as our speaker today. Dr. Cvetkovic is an assistant professor of medicine in the Division of Infectious Diseases here at McMaster University, practicing out of the mostly Hamilton General McMaster Medical Center. She's also a member of the Substance Use Service, a new service a newish service, I should say, in the Department of Medicine right now, providing fantastic work to a very important population. She completed her infectious disease training at McMaster University. Many of us know Anna and worked with Anna closely. In 2021, she completed a one-year Ontario HIV treatment network residency, which focused on the care of women living with HIV and the management of substance use disorders, I should say. Her areas of interest include infections in pregnancy, HIV, and infectious sequelae for substance use. Anna is going to talk to us today about a very important topic, and I was chatting with Anna at the start of this, saying my personal experiences with the patients, similar to what Anna is going to talk to us today about when we are practicing medicine in the city. She's going to talk to us about navigating patient-initiated and unplanned discharge in people with in people who use drugs. So without further ado, I'm sure we're all excited to hear from Anna today. So Dr. Cvetkovic, please go ahead.
Thank you so much, Dr. Azam, for that introduction. Yes, today we'll start by spending some time talking about how to navigate patient-initiated and unplanned discharges in people who use drugs. I think, as Dr. Azam has said, we've all seen this, experienced this, considered how to deal with these challenging situations. And so this will by no means be a prescriptive approach, but it'll be some things to consider and hopefully give us all a little bit more comfort in how to navigate the situations. So first, I'd like to do a land acknowledgement. We are privileged to provide care on the lands of Indigenous peoples that Indigenous peoples have called home for thousands of years. I myself live within the city of Hamilton, which is situated upon the traditional territories of the Erie, Neutral, Huron-Wendat, Haudenosaunee, and Mississaugas. So in terms of the objectives of the talk today, we'll discuss the common misconceptions associated with patient-initiated and unplanned discharges, specifically as it relates to the use of the Mental Health Act. We'll also review challenges that exist and possible approaches in addressing these difficult situations, including examining some instances where involuntary admissions may be considered. And may is always the classic word there, and a very important word. We'll also review examples of Canadian case law that highlight the nuances that exist in clinical decision-making within these scenarios. And so hopefully that will lead us through this. So to give us a little bit of background, we'll first start with sort of discussing patient-initiated discharges. How frequently do they happen? And what are some of those baseline characteristics? So they represent about 1 to 2% of all hospital discharges, which is a significant number. In terms of risk factors that make it more likely, psychiatric illness, substance use disorders, or substance use in general, HIV, hepatitis C, having insecure housing, and having a history of patient-initiated discharges all make those much more likely. In terms of what these discharges are associated with and why we should sort of be worried about them is because they're associated with higher rates of readmission, worse health outcomes, including higher rates of mortality, and of course, higher system costs when patients are coming in readmitted, sometimes with worse sequelae of their initial problem. And this is particularly of concern in people who do use drugs, who are often coming in with severe and life-threatening infections such as bacteremia or endocarditis and septic joints. So how frequent? So within this population, so there was a systematic review that was published in 2015 that examined the rates of patient-initiated discharges. And this was a sort of looking at 17 studies. Out of 13 of them, they listed substance use as the main predictor of patients leaving hospital prematurely. And within people who use drugs, the prevalence was 25 to 30%. So a very significant number, and it's extremely common. Within a Canadian cohort study done in Vancouver, 54% of people who use drugs compared to 23% of patients that don't use drugs left hospital prematurely. So they're very much overrepresented in this when it comes to patient-initiated discharges. So why is this happening? And I think, as Dr. Azam alluded to it at the beginning as well, is we've all seen this. It can be frustrating to both patients and to their providers. And I think, the most important thing is to sort of remember that we need a patient-centered approach to identify the root cause of distress when this is happening. And there have been qualitative studies looking into, so what are some of the things that make it more or less likely? And a few of them are listed there. So suboptimal communication between the care team and their patients. And sometimes that's a perceived suboptimal communication, but it's something that we really need to sort of work on. Poor management of an active substance use disorder, such as withdrawal symptoms. So that is a very common one that's listed in many of these qualitative studies. Abstinence-based policies within hospital settings. So that would mean that there's lack of access to inpatient harm reduction services. There's sometimes stigma and shame associated with substance use, which then sort of leads patients to leave once again. Again, in terms of the risk factors, it's similar to what we had discussed in the previous slide. So insecure housing, unstable employment, a history of incarceration, and then there's other things sort of situationally that make it more likely as well. So whether it be a weekend or a disability pay day. Protective factors, and this is pretty important as well, are in-hospital methadone use, which I imagine would also likely, whether any kind of opiate agonist therapy, whether it be Suboxone and Acadian or safer supply or anything else, being actively engaged with social work, older age, planned discharges to a community-based model of care, and we'll discuss a little bit later what that means. Other groups that are overrepresented in this within patient-initiated discharges are Indigenous groups. However, that may speak to a larger social and systemic factors that are affecting this population, including racism and discrimination. So this is hard, right? These are really challenging clinical situations. They're challenging ethical situations, and especially because what we are doing in essence is we're addressing a patient's autonomy, and we're trying to compare that to how we feel as a clinician and our ethical duty to do no harm. And so these are really challenging situations. And so often when things are not easy, we turn to our licensing bodies to help us sort of navigate these situations. And so I think it'll be important to spend a little bit of time to talk about what our licensing bodies recommend in these situations. So first, we'll start with the CMPA, because often healthcare providers, in an attempt to mitigate the risk, the legal and risk and the liability associated with these situations, have patients sign a leaving hospital against medical advice kind of form. This is a document that is actually recommended by the CMPA to sort of mitigate some of that liability. However, they clearly state on their website here and within their documentation that there is actually, it is extremely uncommon that a court will find a patient wholly responsible for an adverse outcome due to contributory negligence of the patient. So they think that many physicians think that they're absolved of any kind of legal duty or care when the patient is deemed competent and discharge themselves, but that is not the case in a court of law when these are actually brought forward. And I think that's really important to know, that these forms that we make people sign won't really do anything. So they're still recommended. The CMPA still recommends that we do them, but it's not the end all be all of this situation. So what does the Royal College say? So this is another important thing, is that there is nothing within the Royal College they clearly state that it's not possible to have a document that absolves the healthcare team from responsibility for an adverse event. So this is, again, sort of corroborating what the CMPA is saying, is like, do it, but it will not absolve you from any kind of responsibility of an adverse event. So that's why, it's really important for when we're navigating through this, that we don't sort of rely solely on this idea of a patient's decisional capacity, and more so think through the scenario using hopefully the approach I'm going to describe. So why is it so challenging? Like, what is it about these situations that make them so challenging? And I think, of course, we're considering our legal liability, but more importantly, we're trying to consider our ethical responsibility to the patient and how we can ensure that they're getting the best care. And so often, to put a name on it, what we're doing is we're trying to balance the appropriate and necessary patient autonomy with adequate medical care and harm avoidance. And this can be quite challenging in these situations when a patient is initiating their own discharge, and we're trying to decide, can we literally take away their rights, and is that the right thing to do? And are we actually going to provide them with adequate medical care and avoid harm, as opposed to causing them more harm by doing so? And so that's why these situations are so challenging. So I think the biggest thing is that, what we need to remember is that we're trying to avoid these situations altogether. And I'll spend a little bit of time at the end sort of discussing some ways that we can hopefully avoid having this conversation at all. But they are inevitable, these situations, and they're not always, things that we can control that happen. But I think most of the time, empathetic, patient-centered care with appropriate withdrawal management and support may be sufficient in avoiding a premature discharge, but sometimes it's not. And sometimes we need to know exactly how to address these situations. And the best way to do that is to familiarize ourselves with the Mental Health Act and how to actually use it appropriately. So what is the Mental Health Act? So it exists in order to mitigate the risk that is posed in situations where an individual suffering from mental health disorder poses a risk to themselves or others. Physicians outside of psychiatry often lack clarity on the proper use of the Mental Health Act, and I am by no means an expert, but I will hopefully be able to sort of explain my understanding of it, my interpretation of it. And the involuntary admissions can be considered for medically admitted patients who pose imminent risk of harm to themselves or others, or who are at risk of serious physical impairment or an unintentional threat to life or limb. So this is important. You can, we'll sort of navigate the nuances of this, but this is basically saying that this is not a punitive act. This is something to protect the patient and to mitigate the risk posed in these kinds of situations. And so how do we practically do this? Well, in Ontario, what we use is a Form 1. From our perspective, this can then be transferred into a Form 3 by a psychiatrist should they deem that that is appropriate. But from our internist perspective, a Form 1 is what we would use. So in order to be valid, the reasoning provided by the clinician should prove that physical impairment to the patient themselves or others is imminent, which, there's loose definitions of that, but, within 48 hours is kind of what I loosely use. Likely, which means greater than 50% to occur, and that the risk posed is directly a result of a mental health disorder. So it can be initiated by any physician who has assessed the patient at the time of concern, regardless of specialty. And I think that's a really, really important point, because that's sometimes not known. And any physician can actually discontinue a form. It doesn't have to be a psychiatrist. As long as that physician has assessed the patient and has deemed that the criteria are no longer present, they can actually discontinue the form themselves. So how would you fill out a form in these situations? And so we'll go through the nuances of how you actually decide whether or not you're going to use it. But if you were going to fill it out, basically what you would sort of check off, practically speaking, is that this patient has shown or showing a lack of competence for care for himself or herself, and you would use the future test, and you would select the serious physical impairment of himself or herself or themselves. So this is how you would sort of fill it out. And then this would be valid for 72 hours. And then that would have to be reassessed by a psychiatrist should you want to continue it further past the 72-hour point. Sorry, something is in the chat. So someone in the chat has said, is a substance use disorder a mental health emergency? I rarely call psych for substances alone. That is an excellent question, and I hope I'm about to address it. So we will get there. So exactly, that is a really good question. So how do we actually approach the situation? So I will give you a couple of, I'm an internist, I'm not a psychiatrist. So I have a checklist. I have an algorithm that I go through in these situations. And hopefully by describing a few different examples, including later on some case law, this will sort of bring this home, I hope. Okay, so the first step in any of these situations is, does the patient have a life-threatening condition that is more than 50% likely and imminent? And this is from a medical point of view, because I'm not discussing, the Mental Health Act from a psychiatric point of view. I'm saying, if a patient is admitted with a medical condition, so they're admitted to hospital with endocarditis, can we invoke the Mental Health Act, and when is it appropriate to do so in order to keep them in hospital to treat the endocarditis? Okay, so that is different than having someone admitted to treat their psychiatric condition. So number one, okay, sorry, one more question, and reversible. Yeah, so we'll get there again. So does the patient have a life-threatening condition that is more than 50% likely and imminent? So number one, this is not cellulitis. Like cellulitis within 48 hours is not going to kill you. It won't. You'll be sick, but it's not life-threatening. It's not threatening, especially in that time frame. However, if you compare that to somebody who is bacteremic, has endocarditis, has PR prolongation, and you're worried about a root abscess that's going to lead to a significant cardiac arrhythmia, that is life-threatening. It is imminent, and it's probably more than 50% likely that should they leave hospital, they will die, right? So that if that's true, then I move on to the rest. If that's not true, then I stop. Okay. So if that's true, let's say our endocarditis patient with the impending cardiac arrhythmia, I move forward and I say, okay, does this patient have a mental health disorder that is influencing or driving their decision-making? And we'll talk about it. That was sort of to speak to your question, is yes, a substance use disorder is a mental health disorder. And if the substance use disorder in this situation is driving or influencing the decision-making, then, and we have to have clear proof of that, we have to clearly justify that, then I would move forward again in my algorithm. So to sort of give an example, this is not, I have to leave hospital because my cat is not being looked after for the last 3 days. I have to go pick up my check. I haven't heard from my partner for 48 hours and I'm worried that they're ill and I have to leave and go find them. Those are not reasons why I would keep someone in hospital, because their decision-making is not being influenced by a mental health disorder. However, if they were in acute withdrawal and they're saying, I have to leave because my withdrawal is not being managed, I need to go leave to use substances in order to manage my withdrawal, that is a reason, that is clearly their decision-making is being driven by their mental health disorder. And it is not enough for someone to say, yeah, I understand the risk, I accept the risk, I'm leaving. That's not good enough. The person we have to understand what is actually driving their decision-making. It's not enough for them to sort of regurgitate the risks to us. And to give another example from the world of psychiatry, so if you have a patient who is coming in with suicidality, I mean, they will tell you that they understand that if they they're coming in because their concerns are that they're going to harm themselves. And so it is not to do with their capacity to understand risks or their willingness to accept that risk. It has to do with whether or not their decision is actually being driven by mental health disorder. So if that's true, Then we move on. So this is sort of to the point that someone put in the chat as well, is that it's idea of reversibility, but it's more to do with, can you actually mitigate that risk by admitting them to hospital? So an example again is with our patient with endocarditis, impending cardiac arrhythmia. If I keep them in hospital, I can give them antibiotics. I can have them assessed by cardiac surgery, and they can maybe get a valve replacement. And yes, that will mitigate the risk of them having a life-threatening condition that will kill them. So, however, if I compare that to somebody who has, for instance, chronic, like borderline personality disorder, has chronic suicidality, should I admit them to hospital? I'm not really doing I'm not necessarily able to mitigate that risk of that chronic suicide risk. And in our patients, in this patient population specifically, if we think about patients who have opiate use disorders, they have a chronic risk of overdose. Like that is facts. That just exists for them at all times. And so I can't keep them in hospital to prevent them from using substances, because there's no way that I'm going to be able to mitigate the risk of that chronic suicidality. However, to give another example within that patient population, if we're doing a rapid methadone titration, so which is when we increase their methadone by 10 milligrams every single day until they get to a dose of 70 milligrams, and then they stay at that dose for 3 days. The reason we do that is because their methadone is not at steady state. And so their risk of overdose during that period of time is way, way higher because we have no idea how much methadone they're actually getting in their system. And we're trying to do it very, very quickly. And so they have to be under observation. And so both MRP teams and the patient themselves has to consent to staying in hospital that entire time. Should they leave during that time, you could argue that their risk is much, much higher in that period of time. And by keeping them in hospital for that full 7 days, you could mitigate that risk by admitting them. So that's that idea of, can we actually change anything by keeping them in hospital? And then probably the most important, so if you've made it this far, then probably the most important is, have they proven that they cannot be voluntary? So this, doesn't mean that they're leaving the ward and coming back late. It doesn't mean that they're leaving the ward and coming back late even for antibiotics or any kind of medication. It's that they're, leaving hospital and returning sicker and sicker and sicker. They are clearly proving that they have consented to treatment. They want treatment, but they are unable to stay as a result of all the things sort of above. So that's super important. They have to have proven that they cannot be voluntary. Otherwise, this form is not valid. Okay, hopefully that will be more and more clear. So I will give a couple of examples. We'll talk, and I will, there's a Canadian case law in these situations is always published. So if someone was to basically have a Form 1, and then Form 3 was extended by a psychiatrist, they assessed and deemed appropriate, and then extended to be a Form 3. The patient has the opportunity to challenge these forms and the involuntary admission, and then that would go to something called the Consent and Capacity Board. And then that case would be reviewed, and then the decision would be a decision would be made around whether or not to keep it, to uphold the involuntary admission in the form, or to negate it. And so there are two cases that I was hoping that are clearly published, because all consent, like CCB cases, are published, and I hope that they will sort of bring these points home. So we'll start with the first. So this is GL, and I'll sort of read what's the way that they describe the case within the actual documents themselves. So GL is a 27-year-old woman with a history of polysubstance use who was admitted with endocarditis to a hospital in Mississauga, Ontario. Her planned treatment course was 6 weeks of intravenous antibiotics. GL remained in hospital voluntarily. She left grounds on multiple occasions and was late 2 to 3 times for her dose of antibiotics. She never initiated a discharge and always came back to hospital the same day. The physician involved in her care subsequently placed her on a Form 1, then ultimately a Form 3 in an effort to ensure compliance to treatment. She made a claim to the Consent and Capacity Board to contest her involuntary admission. Okay, so hopefully as we're talking, you can sort of hear some of the things that we may wonder about in that situation. Second case and we'll go through the details again at the end, is CG. And so she is a 24-year-old woman in Toronto, Ontario, with a history of known opiate use disorder and no other known mental health disorders. She was admitted to hospital in September 2004 with a bacterial infection. 3 days after her admission, she left hospital against medical advice. 3 days later, she returned to hospital, severely ill and near death, as described by her admitting physician, with evidence of endocarditis with septic emboli. Intravenous antibiotics were initiated for a planned 6 weeks of therapy. She remained in hospital until mid-October, completing only 2.5 weeks of her planned therapy. She returned to hospital 4 days later, disclosing that she had used substances while away. After another 4 days in hospital, she left again, coming back the next day with evidence of opiates in her urine drug screen. At this point, she was placed on a Form 1 by her physician to complete the remainder of her therapy as an inpatient. This was supported by the infectious diseases team, who suggested she required another 7 to 10 days further of antibiotics. And she made a claim as well to the CCB to contest her involuntary admission. So first, we'll sort of consider a couple of things as we go through this and talk a little bit about the pros and cons of initiating the Mental Health Act and why we find these so challenging, and what is it like, why isn't this used all the time? Why are people not qualifying? Like what's going on? And then we'll come back to these cases and discuss them a little bit further. So I think first and foremost, there is, when looking at this list of things, there is such a small number of patients that will actually qualify for this. And I think that's super important to remember, that it is a tiny, tiny number of people that will actually qualify, because they're stringent criteria, because you are truly taking away someone's rights. And so this is appropriately very, very strict. So, what are the considerations when initiating involuntary admission? Like, what are some of the things that we're all thinking about in these situations? And so if we're thinking about the positive outcomes from this, so, there might be possible improved medical outcomes. Completing prescribed therapies without missed doses or early step down to regimens that don't reflect the standard of care, that's very much possible, right? That's likely. Maybe this leads to a decreased rate of morbidity, and maybe a decreased rate of mortality. There haven't really been a lot of, specifically for this indication, there isn't a lot of data out there for the use of the Mental Health Act for medical conditions. And then fewer readmissions related to the same underlying diagnosis. Again, that's very much possible. And then lower health costs to the system, because patients are not sort of being readmitted with worse sequelae and leading to multiple admissions with the same problem. Other things to consider that may be positive outcomes from initiating an involuntary admission is the possible increased opportunity for engagement in substance use disorder treatment and stabilization. And so that's a really important thing to consider. There's lots of studies for around involuntary admissions for patients with substance use disorders, specifically to treat their substance use disorders. And so that it's important not to sort of mix those up. This is specifically talking about someone being admitted to complete their medical treatment in the setting of a substance use disorder. But what can definitely happen is that they're seen by addiction medicine service, they're seen by, or the substance use service, they're seen by an addictions counselor, and they're engaged in care. And then this then leads to ongoing care as an outpatient. And then the other thing to consider as well is the risks of what if, what if we don't do this when it is appropriate, and the consequences that are involved with that. So, the risk of mortality, the risk of morbidity, and then of course the medical legal liability should there be a negative outcome as described by both the CPSO and the CMPA. So those are kind of the things that are weighing on us, of course. And then there's the other side of things. So, the cons of these situations, and we're stigmatizing a patient population that's already really suffered from lots of stigma in the past. A lot of the information around this, around involuntary admission specifically, does come from the from acute psychiatric crises and the study around that. And a lot of experience from those settings do lead clinicians to have a lot of fear around about initiating them, and they feel that they're associated with fear from the patient as well, a low satisfaction with care. They're sometimes concerned about the additional cost and time associated with attending a consent to capacity board should this form be challenged. That is all very, very much real and true. And I think it's also important to remember that this is a patient population that there have been studies, including a study by Chin and Kursan, that looked at patients' experience within the hospital setting, specifically people who use drugs, and they consistently say that they feel that they are negatively perceived by their healthcare team. They're described as chaotic and non-compliant and quite difficult, and they see the hospital as a risk environment. And so those are really serious things. And so we don't want to do this lightly, right? We don't want to cause harm. That is literally the thing that we are trying to avoid. And so it's really important for that reason to make these decisions very, very cautiously, and but use it when appropriate. The other concern that people often will have in these situations is severing the therapeutic relationship. And of course, this is possible, and it can happen, and it does happen. But it is also important to consider some of the things that make it less likely. And so there is, again, much of this comes from the world of inpatient, like involuntary admissions for psychiatric conditions, but for like an acute psychiatric crisis. But things that make this less likely are if a patient has had a longer period of time post their involuntary admission, they qualitatively, they've described that they have felt better about their involuntary admission the further away they are from it, which kind of makes sense. They've had time to sort of, maybe they're in a period of more stability, and they've sort of been able to reflect on the positive aspects of it. If they have experienced perceived symptom improvement post-admission, that also makes it more likely. Male gender, for whatever reason, better awareness of illness and diagnosis, awareness of illness. So if they have a better awareness of their underlying diagnosis, and then a diagnosis other than schizophrenia, and older age, all those things make it less likely that they will feel negatively about their involuntary admission, and it's unlikely to sever the therapeutic relationship. And so, in that specific study where they were describing this, they were talking about, what can we do to make sure that that doesn't happen? And it's really enhanced therapeutic relationships. So, getting to know our patients, making sure that they feel heard and listened to, and then really maximizing opportunities for patients to regain a sense of control. So constantly sort of reevaluating whether or not they still have to be involuntary, whether or not there's anything else that can sort of change. To give them more of that sense of control. And then other cons in these situations and other difficulties is that the Mental Health Act is often inappropriately used because we don't have a lot of comfort with it. And because we don't have a lot of comfort with it, then we often sometimes fear it, or we avoid it because we don't want the litigation or the challenges associated with it. And so then there are also instances where we're either using it too much or too little or inappropriately. So what do we do? Like, how do we navigate these situations? And I think the most important thing is that it's not prescriptive. There is an algorithm that I kind of go through, but it's not prescriptive. It is extremely patient-centered. It has to be patient-focused. You have to treat every patient with compassion and individually, and really sort of look at the nuances. But it's really hard. It's super hard, especially when we consider the negative experiences some of these patients have already had. But I think the first thing that we can do is certainly familiarize ourselves with the Mental Health Act, which hopefully we've done. And then I think the other things that we can do, there's a few other things that I think would help improve the care that this patient population is getting. And so we'll go through that as well. So number one is early consultation of an addiction medicine or a substance use service here locally expert, or equivalent consult liaison practitioner during an admission to hospital. not every place has this. We are in some ways lucky to have this as well. And so I think, it's a resource that can really help, and actually has this has been studied as well. And there's been multiple qualitative studies that have looked at, does this make a difference? And so, yes, it's feasible to consult them early. It leads to successful interactions. It engages patients in care. It provides evidence-based addiction management, and also it increases the likelihood of transition to outpatient addiction medicine services and opiate agonist therapy. And there was another study that looked at it, Wakeman et al., that found that inpatient consult services from addiction medicine increased the number of days of abstinence post-hospital at the 1 month follow-up. And not to say that, abstinences are end all be all, but certainly it does speak to the idea that there is engagement of care with outpatient services once they've been seen as an inpatient. So consult early. Other things that will help as well is, early recognition and aggressive management of withdrawal symptoms. So we've, as we discussed, poorly controlled withdrawal has been linked with increased rates of patient-initiated discharges. It is what's sort of driving that decision-making. So it is, and there have been multiple studies also looking at the fact that reportedly many internists feel a discomfort with managing substance use disorders and withdrawal. And so, increased training of healthcare providers within addiction medicine, including medical students and residents and faculty, would probably help us all have more comfort within this area. And then also have an increased feeling of competence managing acute withdrawal until your colleagues are able to come and help. And then if you don't have a service, then again building that comfort yourself. And then hopefully the more you see it, the more you manage it, that will inherently reduce the stigma and internalized, right? Like, this is not something that we are outwardly doing or maliciously doing. This is something that is internalized and can come out in unfortunate ways. And so hopefully by exposure, you can reduce that stigma and discrimination. And then other things that we can do and consider is a more permissive approach to existing abstinence-based in hospital policies. So there was a Vancouver qualitative study that interviewed 30 patients who had initiated premature discharges in the last 2 years in their hospital. And they sort of had discussed, what would have changed what would have led to better retention of them in hospital. And they had consistently described hospital-based harm reduction interventions. So whether that be a supervised consumption site or service on site, opiate-assisted treatment as well. They felt that this would prioritize their hospital care access and improve management of both their pain and withdrawal. It would help lead to a safer environment as well, because as we say, for many people, this is a risk environment, the hospital. So it's important to make sure that they feel safe. And then I'm wondering, would this then lead to higher retention and potentially reduce poor health outcomes because they're able to stay for longer durations to complete their acute medical treatment? And then this is another thing to consider, is there a role for the consideration of combined addiction medicine and infectious diseases discharge rounds on patients with substance use disorders admitted with hospital infections? So there was a quality improvement study done at the New York School of Medicine. And basically what they looked at was every 2 weeks, ID fellows identified patients on their inpatient list with infectious complications of substance use. And then they had weekly case conferences with ID and addiction medicine. And they sort of looked at, okay, who could be linked with a substance use service. And basically out of that, they found that 75% of their patients were then initiated on opiate agonist therapy because of that link that was made. I think, from my perspective as well, I think that this would be really helpful. I think it would help coordinate discharge planning very well. And I think, you could sort of then consider, they're not currently housed. We can't really do IV therapy that easily. Should we do that, they would have to remain in hospital or wait for transitional care bed. Is there, there's all that navigation and discussion that can happen. And I think it would help if the teams are coordinated. It would help really the patient navigate what can be a very challenging situation with everything else that's sort of going on in their lives. And then the fifth thing sort of to consider in terms of, optimizing care delivery is the consideration of something called a community care model of care. So in Vancouver in 2005, they had published a study about this community transitional care team. Basically, they had 9 independent rooms. They had meals provided, 24-hour nursing care, 24-hour mental health workers, physician coverage Monday to Friday with on-call 24/7 access. So somewhat similar to our transitional care beds program. And they basically, but a little bit different, but their patients were basically discharged. If they'd had unstable housing and had a history of substance use, they would basically be discharged to this community transitional care team. And they would stay there until they completed their antibiotic therapy. And they found that when they examined this actually decreased their patient-initiated discharges by a significant amount. And they actually found that when they looked at, out of the 50 patient-initiated discharges that occurred during that study period, only 2 were among those that were staying at the CT, compared to 48 that were in hospital. So that's a pretty big difference. So coming back to our cases, what happened with them? So this is GL. This is our patient who, if you recall, she was remaining voluntary. She had left the ward, had come back late, but had never really initiated her own discharge. And the reasoning written on the form was that she would comply with treatment. And so no surprises, this one was not upheld. And I think that basically it makes sense. This was, you can't take away someone's rights because they're not following the rules. There has to be much more to it than that, as we know. But this one is quite important to review in detail. So again, this case, CG was taken to the CCB, and the decision here was to uphold her involuntary admission. Her position, and this is the thing about the CCBs, is that people can sort of go back and forth and say why they feel that their form was invalid. So her position was that it was invalid because she was willing to be a voluntary patient, and that a substance use disorder was not a mental health disorder that disqualified the use of the Mental Health Act. The CCB upheld the form because they felt that she demonstrated that she was unlikely to be able to remain in hospital as a voluntary patient because she had 4 departures from hospital within 6 weeks. And then the additional important factor was that there was demonstration that with interruption of antibiotic therapy, her bacterial illness was likely to worsen with imminent life-threatening consequences. So back to sort of exactly what we were talking about. And so they did uphold the notion as well that a substance use disorder is a mental health disorder, and that her substance use disorder directly put her at risk of physical impairment. And so that's how we pick that on our form as well. So this is really a case that sort of describes, this is the patient that would have qualified. Okay, and this is sort of exactly from the CCB. So she's not suitable to be a voluntary patient. She's to remain involuntarily pursuant to the Form 4 because she was on a Form 3. So what can we take away from this? So what are some of the conclusions? So, that's a question. Sorry, just looking at the chat here. So it says, when the courts feel that the physician has not done enough and therefore is liable for the outcome despite the patient signing a waiver at discharge AMA, what were the things the courts expected the physician to do? I mean, I don't have an example to answer that question in terms of, what was a situation where it didn't go right. I think the take-home message there is that there is nothing that we can do that will not make us not liable. We are always liable. And even if they sign it, we're always liable. That doesn't mean that, someone's going to take our license away or we're going to be, that's not going to happen. But I think, or there's going to be some sort of punitive action, but I do think documentation is going to be really important. And I think some documentation that you've gone through these steps and considered, whether or not an involuntary admission was appropriate would probably speak highly to the courts. But I am not a lawyer and I am not, an expert in terms of that, but that's what I would think. Second question is, what is the definition of a mental health disorder? Does it have to have a DSM diagnosis? Is delirium a mental health disorder? So yes, it has to be in the DSM. Substance use, this is specific for substance use. Again, I'm an internist with an interest in ID and addictions. Like I am not a psychiatrist. I want to be made very clear about that. But yes, a mental health disorder, like all mental health disorders, have DSM criteria, is my understanding. And delirium is described, but that is a different. I would approach that differently than I would approach this. Because that might be a different conversation. So I hope that helps. And then there's more. Oops. Okay. So when there are gray zones in the directives, including Mental Health Act, the physician-related variables become very important. Physician experience, personal beliefs, understanding the picture more broadly. Any thoughts, reconciliation strategies? Yeah, I think these are extremely challenging, and I think physician experience and personal beliefs are 100% going to impact us. I think a thing to consider for sure is talking to your providers. Like very, very rarely are these patients on an inpatient service and there's no consultants or no other people around or no one else to call. So I think talk to your colleagues and discuss these cases. I think if we were to have more discussions around this, then we would all start to feel more comfortable. It's easy when we're all sort of like really busy services. We're like, okay, well, they're leaving. Okay, they're off my list. But I think it's really important to sort of reach out to each other and talk about it, and call. I've certainly done that. I've called CL Psychiatry to help me through situations. I've spoken to other members of the substance use service, reaching out to more senior colleagues. Like I think really that open lines of communication would help. Yeah, and I think so. Another good point is that, of course, yeah, in terms of like what else would be helpful is arranging outpatient plan at time of unplanned discharge. Yes, sorry. So again, in terms of delirium is would fall under the Healthcare Consent Act as opposed to the Mental Health Act, because it does not qualify as a mental health disorder, though I think it is in the DSM. Okay, so we'll just review and then we can come back to questions again. So common misconceptions: physicians are absolved of any legal duty of care when patients deemed to be competent discharge themselves against medical advice. Nope, that's not true. They are not absolved. Having a patient sign a discharge against medical advice form relieves the healthcare team of culpability from any associated negative outcomes. So again, that's not true. So really important for us to consider those situations. A substance use disorder does not qualify as a mental health disorder. So again, it sure does. It is a mental health disorder. Only psychiatrists and family physicians can initiate a Form 1 under the Mental Health Act. So again, that's not true. Any physician can that has assessed the patient and has deemed it appropriate. And then a Form 1 must be discontinued by a psychiatrist. So again, that's not true. Any physician can do it as long as they've assessed the patient and deem that their criteria are not valid. The only, a Form 1 is what we can do. We cannot do Form 3s. So after that 72 hours, they have to be assessed by a psychiatrist if you feel that the form needs to be continued further. And then takeaway points from case law. So substance use disorders are considered to be mental health disorders and may qualify for initiation of an involuntary admission under the Mental Health Act when other conditions for involuntary admissions are met. That's an important thing. Life-threatening medical conditions such as endocarditis can be captured by the physical impairment clause in box A of a Form 1, as long as harm is likely and imminent. The patient must demonstrate that they are not suitable for voluntary status and that predominant driving factor is a mental health disorder. In this instance, it would be their substance use disorder. Involuntary admissions are not punitive. That's really important. They are a way to treat both the acute medical condition and an opportunity to initiate substance use treatments, such as opiate agonist therapy and management of withdrawal. They're extremely challenging situations, and every case should be evaluated on an individual basis to see if criteria for involuntary admission are present. Whoops. I think someone else posted in the chat. So in the legal cases around someone leaving hospital against medical advice, the issues have been either poor or no documentation of conversations with patients explaining risks, failure to arrange follow-up in the community, or failing to provide the patients with prescriptions that were necessary for treatment. Yeah. Okay. 100%. So I think that's, again, speaks to documentation. Really important to document this and to have, proven that you have actually considered this as opposed to letting folks leave. And then another comment was, as a specialist managing addictions for decades before substance use disorders. Yeah, contacting the patient once they have left, often their phone has been stolen. Yes. So the contacting post is quite difficult. There are again, reaching out to substance use service if they are involved is sometimes helpful, because you can find them sometimes at their pharmacist. If you know which clinic they go to, sometimes we can find them there. But yeah, that is definitely a concern. If they've left without us being able to have a conversation with them, that can be challenging. I will say, often if within the community, it is a smaller community, we can often find them, but it can be quite challenging. Okay, more questions. How do you deal with medical conditions that are worrisome but not definitively worked up, abnormal tests and risks, but echo pending culture results can't? Yeah, those are really challenging situations. I think, in that situation, you kind of, it is to do with, clinical experience and what your concerns are. I would say there probably isn't enough there to be able to actually form somebody. If it's just a worry and you have no definitive proof, I think, should that go to a consent and capacity board, that would probably be overturned, unless in the end it ended up being something really concerning. I will say a form 72 hours, not to say that we should use them lightly. I think, you have to be really, really worried. You have to be extremely worried that this is life-threatening, and everything else has to be there as well. But yeah, you have 72 hours. Yeah, for sure. So creating an unplanned discharge plan from day one makes a lot of sense. I think it's important to of course, have a contingency plan, know what you're going to do if they leave, but not assume that people are going to leave either. I think that's where we don't want to sort of perpetuate that pattern or that idea either. But I think definitely communication within the team would be really important to have a backup plan. But not necessarily assume that someone is going to leave, because they may not. Okay, perfect. Doesn't look like there's any further questions for now.
Fantastic, and this is really, really helpful, and I love the practical approach to it, and understand the complexity. I don't know if you want to expand a little bit about the follow-up. Sorry, I mean, we understand, we called against medical advice, so there's this idea that they're leaving, it's their decision, right? But I love the concept of patient-initiated discharge rather than against medical advice term. I think that maybe we need to use some different language to change our own mental situation in these cases. So in the follow-up piece, which is pretty complex, especially if you can't reach out the patient. Do you want to expand a little bit on that, if possible?
Yeah, for sure. I think the follow-up piece is challenging. So I think it depends. So I think if the patient's in front of you, you deem that they're that they're appropriate for an involuntary admission, and you're going to keep them, then the follow-up is basically you assess them every single day to make sure that that's still the case. Hopefully, in the meantime, you are managing whatever it is that is actually driving this desire to leave. So if it's their withdrawal, you are aggressively managing their withdrawal. And then at the 72-hour mark, hopefully by then it's no longer valid and you let it lapse. And if there's still concerns, then you, at that point, somewhere within there, you would have called psychiatry to continue it. If we're talking like follow up from the actual that, if we're talking like we want to, someone has left hospital or is leaving hospital and they do not meet criteria for a form, and we're trying to figure out what to do. I think there's a lot of really helpful things in the comments there. Is I think first and foremost, like communicate what your thought process was, like what did you think about, how did you navigate the situation within that discharge note. And then I think also talk to the other services provided to sort of decide, okay, how are we going to make this the safest discharge possible? So does that mean I'm going to send my prescription to where they're on methadone, they're probably going to show up to their pharmacy. I'm going to send my antibiotic to that pharmacy directly, as opposed to just, hoping that they show up at the general's inpatient pharmacy, like outpatient pharmacy. So I think I would send it, and have that conversation with them. I would, and also, I mean, a lot of the time people, if they do leave, they will have a conversation with you about it. And so I think engaging with them, saying, okay, I understand you got to leave. How do we make this safest as possible? And, sort of trying to coordinate their care and trying to really meet them where they're at in terms of where they're able to go. I hope that answers your question. It's hard.
It does cover a lot of things that it comes to my mind when we send a patient, our patient leaves, and my experience, actually is more patients that are in the challenging situations, because you can't talk the patient into staying. It's a patient that just disappear on us, right? So
yeah,
absconded, terminology.
Yeah, I think.
Yeah, go ahead. Yeah.
No, I mean, those are really challenging situations. I think if people leave without our and sort of disappear without our ability to know where they are, those are challenging because you haven't been able to assess them at that time to sort of decide whether or not the criteria are met. And I think that is where it's challenging. You kind of have to have assessed them with, like, that for this to be valid, you have to have assessed them in order to be able to say whether or not these forms are valid. And whether or not they have a life-threatening imminent risk, whether or not they're, what is their decision-making? Like, we have no idea why they left. Like, maybe they left because they had a job to go to. Like, we don't know if they just left. So in those situations, like, unfortunately, it is quite challenging. And I don't think you probably could enact an involuntary admission unless you had some sort of proof beforehand to suggest it. And then, like, we really try to avoid it, but ultimately, like, it would be a code yellow kind of situation, and you would try to do a safety check. You might have to get the police involved. You would really try to avoid all of that. That would be like last ditch efforts, because again, you don't want to make it like a really stigmatizing, really challenging, really risky situation for them. And then also, you don't want them to never come back to hospital again. So there, there is all those factors. So these are not easy situations. So I don't have answers. I only have thoughts.
Very important. You've touched on code yellow, and I was going to bring it up because it is the hostile policy, code yellow, which is, unfortunately, everyone struggles with. The level, stage 1 is looking at the premises, stage 2 looking around the premises, stage 3 involving police, which is the most recent I've been involved in. I actually did not escalate to stage 3 because our policies are limited by involving the police, actually. And and again, this is really a difficult situation that you should not probably involve the police, and we should have other resources to access or locate those patients that they need the help other than the police, because what they want is form them, and then they go shackle them and bring them in, which is not what we want to happen in our patient population. So it's really complicated situation that our system
For sure. And I think the one thing I would also mention is that because, a lot of patients are engaged with peer support workers, they have, they're involved with the Shelter Health Network or Keeping Six or some of our other community programs. Sometimes we can find them without having to escalate to that. And I certainly have in some situations where I'm like really concerned about someone, but I don't have grounds to, involuntarily admit them, because again, this is extremely rare where someone would actually qualify. I would reach out to those providers and say, hey, have you seen this person? Do you know where I could find them? Can we sort of engage with them, or are you able to see them at your community clinic? So I think, yeah, it's not, yeah, it's really, really challenging. But yeah, I would not use the code yellow system unless it was unless they were formed and it was necessary.
Thank you so much for this fantastic, very practical, very useful grand rounds this morning, using your expertise and knowledge, and very interactive discussion on the chat and the questions. So it's been fantastic. Thank you very much, and wish everyone a great rest of your day.
Thank you.